asked me that a long time ago, several months ago, was to talk about sedatives and weaning of sedatives in the setting of spontaneous awakening breathing trials. So it's a topic I didn't realize there was a whole lot to say about, and then when I did some digging, I mean, I think there's more to say than meets the eye. One way to start talking about this is to kind of refresh ourselves of what these drugs do that we're using for sedation and analgesia. And this is my way of thinking about it. So the categories are anxiolysis, which is sort of mild depression of a level of consciousness, and then this, which is decreased level of consciousness to the point that the patient is unresponsive. So these are kind of a spectrum. They're not like necessarily clearly different categories, but I think about anxiolysis as like, the patient's nervous and you give them something, and this medication has the effect of breaking that anxiety without making them unresponsive. So these two can be sort of separated up conceptually that way. Analgesia is another category: decreased patient movement, decreased respiratory rate, and then we can add some additional steps. So starting with propofol and barbiturates, we don't necessarily think of these as the same drug, but they have really, really similar effects on the brain. And the biggest difference is the time of onset and time of offset. Propofol is fast on, fast off. Barbiturates tend to be longer to come on, longer to come off. That's the biggest difference, but they have very similar effects. So do they have anxiolytic effects in your all's experience? Propofol being the one you guys have the most experience with. If you give somebody propofol and they're anxious, are they likely to be less anxious?
Yes.
Yeah. Okay. Does it decrease your level of consciousness?
Yes.
Yep. Does it provide analgesia to your patients?
No.
Not really. Not as far as anybody's been able to show. No meaningful amount. One way you can figure that out is basically by like taking rats and giving them propofol, and then subjecting them to painful stimuli, like putting them on a hot plate. And apparently, the rats' vital signs react as though they're in pain, even though they may not be able to respond. They don't like move their paws from the hot plate. They respond as though they're experiencing pain in terms of their heart rate and blood pressure and things like that. So that's how we know that propofol doesn't really provide analgesia, even though it may depress consciousness. Does it make your patients move less when you give them propofol?
Yes.
Yep. Does it decrease their respiratory rate? Yeah. Okay. All right, cool. So what about opioids? When you give your patients opioids, does it relax them? Yeah. Does it decrease their level of consciousness? Yeah. I agree. Do opioids provide analgesia? Yep. Do they decrease your patient's movement? Yeah. This is kind of a hard category to. This is my wording for it, but yeah, I think you give them enough opioids, patients are going to stop moving. Do opioids decrease respiratory rate? Yes. Okay, perfect. All right. What about dexmedetomidine? Does it provide anxiolysis? Yeah. Does it depress the patient's level of consciousness? Yeah, it's sort of like not much, but maybe a little bit. Does it provide analgesia?
Some.
This is harder. Yeah, it's mild, very mild analgesic. It's sort of the equivalent of giving your patients IV Tylenol. So think of it that way. It's it's not a tremendous amount. Does it decrease your patient's movement? Yeah, it's sort of kind of to the same degree that it depresses the level of consciousness, minimally. So a little bit. Does it depress respiratory rate? Not really, yeah. It really shouldn't. I've seen some cases where somebody has a lot of other respiratory depressants on board, and if somebody's already on, let's say, benzos and opioids, and you throw dexmedetomidine at them, the dexmedetomidine might be what pushes them over the edge to apnea, but by itself, it's really not much of a respiratory depressant. What about ketamine? Does it provide anxiolysis? This is a tricky thing. It really has such variable effects on patients. So some patients it might calm them down, some patients it might make them more agitated. So this is sort of a plus minus. Does it depress your patient's level of consciousness? And specifically, I'll say at the doses that we use in the ICU, which are less than 10 mics per kilo per minute. It really shouldn't do much to depress level of consciousness. It's more that it causes audio-visual hallucinations. The more changes the level of consciousness it doesn't necessarily depress it. Does ketamine provide analgesia? Yeah, that's one of its potent effects. It provides analgesia. Does it decrease your patient's movement? That's a hard one.
Sometimes it does, and sometimes it aggravates it.
Yeah. So kind of variable effects depending on what impact it has on their sensorium. Does it decrease the patient's respiratory rate?
Generally.
Yeah, generally not. So I would say like we can put an N here because we don't have a whole lot of blanks. We'll put an N. I'll make it red so that so it stands out a little bit. Most of these drugs hit a lot of different attributes, but so it's easier almost to identify what they don't do. Okay, what about, I included lidocaine for completeness. John, if you want to help show this, if anybody that hasn't gotten food yet, please help yourselves. Lidocaine, does it provide anxiolysis if your patients are on a lidocaine drip? It's a tough one. I think if their anxiety was driven by pain, then it might provide some anxiolysis, but for the most part, it probably doesn't do a whole lot. So I'll just go ahead and check out the pain box. Does it depress a patient's level of consciousness? It shouldn't, yeah. It's sort of like at the doses we usually use, it shouldn't. If it does, then you're getting into toxic levels. So it's capable, it is capable of depressing a patient's level of consciousness at toxic levels. But at the doses that we use, it really shouldn't be doing much of that. I'm just going to fill out the rest of this because lidocaine's a tricky one. Decreasing patient movement, it's sort of like, if they were agitated from pain and you give them lidocaine and it makes the pain less, then maybe they'll move around less. It shouldn't really have an effect on your respiratory rate. So lidocaine drips should not have much of an impact on your respiratory rate. Okay. The whole reason I included the movement category was I wanted to add neuromuscular blockers to this list. So do neuromuscular blockers provide anxiolysis?
No.
No. Okay, that's important. Do they decrease a patient's level of consciousness? No. Do they provide analgesia? No. Do they decrease patient movement?
Yes.
Yes. Yeah, that's the main thing that they do. Do they decrease a patient's respiratory rate?
Yes.
Yeah. Usually, if you're giving in high enough doses, they'll stop your patient from breathing. Okay. What about benzos? Do they provide anxiolysis?
Yes.
Okay. Do they decrease patient's level of consciousness? It's kind of dose dependent. Tiny doses maybe not, but as we put people on benzo drips, they tend to have decreased level of consciousness. What about, do they provide analgesia? Not really. Yeah, it's similar to propofol. It's sort of it depresses level of consciousness without really providing analgesia. Does it make your patients move around less to be on benzo drips? Okay. And does it decrease your respiratory rate? Yeah, for most patients it will. If you give somebody benzos in isolation and no other medications, it may not have much of an effect, but if you give benzos with any other respiratory depressant, the benzos will make the respiratory depressant effects really exaggerated of the other medication. So I'll put a plus sign here. Okay, any questions so far about this? Okay, so let me give you some scenarios that I've run into. I've had questions asked me about before we move on to spontaneous and weakening breathing trials. Like, let's say we have a scenario of, okay, patient is chemically paralyzed. With cisatracurium drip. They're on propofol at 25 mics per kilo per minute. And they're on fentanyl at 50 mics per kilo per minute, and the BIS is reading 70. Question is, and otherwise they're doing fine on the vent. They've been chemically paralyzed for ARDS, so they are in a 24-hour period where they're going to stay on cisatracurium. What's the problem, if any, and what would you want to do to adjust that?
Your BIS is high.
Yep. Okay. What's your goal BIS?
35 to 45. 35 to 65?
Yeah,
Is it?
yeah.
40 60.
30
How's
to 60,
that?
yeah.
It's not multiple choice.
Yeah, something like 30 to 60 is good. Okay, and then so your BIS is high. So what medication adjustment would you want to make? Do you want to go up on the propofol? Do you want to go up on the fentanyl? Do you want to add a new medication?
There's some ways to do it.
What? Yeah, there's a difference.
Pain or yeah.
If the tank hits, like,
Pain,
So here's the thing. No matter how much you go up on the fentanyl, you can't really assess pain underneath chemical paralysis, but you can assess their level of consciousness. That's what the BIS number tells you. The problem with going up on the fentanyl is that even at really high doses of opioids, you don't reliably depress consciousness enough. So let's see, well, we have opioids. Level of consciousness is depressed, but one category I didn't have on here is, I'll just create it to give you guys a sense of, is recall. Recall of ICU stay. It's related to your level of consciousness, but there's not a 100% relationship. So propofol will decrease your recall of an ICU stay. Benzos will diminish that, but opioids may or may not. They're not good at even though you may have a depressed level of consciousness, you may still recall being in an ICU. You may remember having a breathing tube in. You may remember being poked and prodded while you were immobile and couldn't move. So if your BIS is high and you can't assess pain underneath chemical paralysis, the answer is not to go up on the fentanyl. It's actually go up on the propofol. And if your patient's blood pressure can't handle that increase, then you need to talk to your provider and see what can be done to get them to tolerate the propofol increase. Or they might need to have another drug. I hate benzos, but in some cases we add benzos on here. There's a lot, but opioids by themselves are not very good. And I'll just go down. So this dexmedetomidine is probably not very good at diminishing recall of your ICU stay. Ketamine, unclear. Lidocaine is probably not very good, and neuromuscular markers definitely aren't very good. So that's one scenario. The main thing you're focused on when you come with paralyzed patients is avoiding a high BIS number, and it's your propofol and your benzos that help reduce that. You want to have some opioid on board, but it's really this is a titratable thing on your chemical. Any questions about that? Okay. All right, so now spontaneous awakening, spontaneous breathing trials. First, let's define what these mean in simple kind of conversational terms. Like, what does spontaneous awakening trial mean to you guys?
Like a neuro exam.
Yeah, that's a good way to think about it. Yeah, neuro exam. Okay, can the patient follow, starting with can the patient follow simple commands? Okay, what about a spontaneous breathing trial?
Lower, it's like the pressure support or something like that.
Capable of breathing.
Yeah.
Yeah. Okay. It's a trial of spontaneous breathing with minimal vent settings. Breathing with minimal vent settings. So what people define as minimal vent settings varies depending on where you read. I think about it as like pressure support 8/8 or less. Some people will change these numbers around, but it's a ballpark. Something that will simulate what it will be like for the patient to breathe disconnected from the ventilator completely when the breathing tube is removed. That's the spontaneous breathing trial. Okay, so what's the rationale for why we want to be doing these whenever it's safe to do so? Why do we want to do each of these on a daily basis?
Check the patient is able to follow commands and
What's that?
to check if the patient is able to follow commands and take deep breaths, on command.
What's the reason? Why is it important that we do these on a daily basis if the patient is eligible for it?
Able to what do you call it? Protect their airway.
Well,
Right?
you're getting at why they were what
Okay,
you're getting at, should we extubate them or not, right?
Yes.
But the question is why is the standard of care in critical care medicine for us to be doing a spontaneous awakening trial, a spontaneous breathing trial on a daily basis in
Well,
patients?
spontaneous awakening is if he was neuro intact before he went in,
Okay.
you want to make sure he stays neuro.
Yeah.
There's no real change in neuro.
Okay, that's a good
every
reason.
state.
You want to use the least amount of
Yeah.
potentially deliriogenic.
Yeah,
medication.
exactly. So these are
That's
two
right.
categories. One category is it allows us to continue our assessment of the patient. These are logical reasons. The other category of reasons is evidence-based support for this practice. People have found that there's a group, primarily in Vanderbilt, where they've done a series of trials that were published in like high tier journals like JAMA over a span of the past 20 years. And first they took a gray-haired physician's best judgment, weaning patients with a ventilator, versus a protocol that included a spontaneous breathing trial daily. And they found that there was a mortality benefit, not just a decrease in ICU length of stay, not just a decrease in delirium, not just a decrease in ventilator days or hospital length of stay, but a mortality benefit to implementing a daily spontaneous breathing trial, which is an impressive finding. Then they said, okay, how about we give everybody a spontaneous breathing trial, and then we randomize some people to get a spontaneous awakening trial, and they found there was a mortality benefit to that. So basically, what the outcome of this is that it's now, basically for 10 plus years, it's the standard of care for us to be considering doing a spontaneous breathing trial, because patients die more if we don't do that. And the reasons for that are complex and we don't fully understand it, but probably has to do with the cumulative sedative load that we give them is predisposes them to delirium. And as we all know, delirium is associated with all kinds of other bad stuff and is very hard to deal with, and patients do worse when they get delirious. Any questions about that? Okay, so then, the rationale is basic, to continue our advancement of their care and to provide evidence-based standard of care. That's why we do these daily. So the safety screen, I found some stuff online about how what safety screen criteria are used at other institutions. The one that Reed showed me the Durham VA protocol here, which I wasn't.
Yes.
I wasn't aware of myself, but it has a lot more stuff than you'll find you will find in other kind of generic protocols. So, like, one big picture way to think about it before I get into like the criteria is the following. So, can your patient follow simple commands? Simple commands while they're intubated. If yes, then you move on to a spontaneous breathing trial. If no, you need to decrease your sedatives and then do a spontaneous awakening trial. And then, I'm missing a step here. So I'm missing a safety screen here. So let's do safety screen, SBT safety screen, passed. If yes, then the patient will go on to an SBT. If no, then you basically just continue care, and then you kind of reassess in 24 hours. If the patient wasn't able to follow the commands, you decrease your safety screen here. Spontaneous beginning trial screen passed. If no, you reassess in 24 hours. If yes, then you decrease your sedatives. And then you reassess basically here. And then you keep going. I made it a little bit confusing, but okay. You keep going until they're able to follow simple commands, and then you do your spontaneous breathing trial screen. And if they pass that screen, you actually do the spontaneous breathing trial. If they don't pass that screen, you just come back to it. So, bottom line is, if they're already following simple commands, then they've essentially passed their spontaneous awakening trial. That's the goal, as Reed said. It's basically a neuro exam. If they pass their spontaneous awakening trial, either through weaning of sedatives or even before you start the weaning of sedatives, then you see if it's safe to do a spontaneous breathing trial, and if so, the RTs will do that. And if at any point they fail either a safety screen or they fail the awakening trial because they get agitated or something, then you basically you go back to the drawing board, and then you typically wait 24 hours to change that. Unless there's something obviously fixable that you can do, like obviously fixable things are if the patient, this is now coming to how we would actually physically do this. So there's a lot of variability, as Reed pointed out to me, in terms of when you guys are told to do a spontaneous awakening trial, some people ask you to wean sedatives, some people ask you to stop entirely. Part of that depends on what's going on with the patient. Part of that depends on the class of medications that you're using. Okay, so for instance, if let's go through another scenario here. So your patient is they're intubated, they're unresponsive, and you are on not responsive, intubated. Okay, you're on propofol at 100, and you're on fentanyl at 100. How have you guys seen people wean these or stop these, or what's your instinct in that situation?
At most of the places I've been has been to do a sedation vacation where you stop them and then see where they wake up and then start it back at half and then work if you need to go up from that. Then
Yeah, that's perfectly reasonable. I think the only time I would be more cautious than that is if the patient has been consistently agitated during spontaneous awakening trials before, in which case you can consider something like, decreasing by 50%, wait 30 to 60 minutes, and then reassess. So it kind of depends, how wild and agitated was the patient to the point that if the reason why they're on relatively high doses of propofol and fentanyl is because they've been buck wild, then you might want to go slow. If they've had relatively cooperative neuro exams up until that point, then completely stopping is totally reasonable. And then of course, if we get to the point where let's say we've turned off the propofol completely, we've turned off the fentanyl completely, and we just keep they alternate between being unresponsive on any amount of sedation or wildly agitated on zero sedation. What alternative do we have that we use all the time? If you turn off, if you're kind of in a seesaw where they require sedation to tolerate the breathing tube, but whenever you start the sedation, you get poor neuro exam. Like they have a weak cough, they're not consistently following commands. Then you turn off the sedation and they're RAS of 4. Then what's
Different medicine.
Yeah, what medication?
Dex.
Yeah, Dex. Yeah, exactly. Our classic dextubation is a treatment for this dexmedetomidine, and it comes back to kind of its property is that it's not a respiratory depressant by itself. It has mild analgesic properties. It has some anxiolytic properties. Minimally impacts level of consciousness, and so dexmedetomidine also some patients get overly sedated with it, and so when you guys are weaning or turning off Dex, what kind of protocols do you guys have in your mind when you're dealing with Dex during a dextubation? Like, let's say you transition from propofol to this is the second case. You've transitioned from propofol to dexmedetomidine at 1.5 mics per kilo per minute, and the patient is they're breathing fine, but they're not really consistently following commands, a little bit groggy. How do you guys address that situation?
Depends on the beer level of the patient. I was kidding.
Yeah.
Basically adjusted at 1.5, you cut back to like 1.
Yeah. There's no.
You cut it back.
Yeah, you
based
can.
on heart rate and blood pressure also.
That's true. What do you mean? What do you mean by that?
Because sometimes with too much Dex it causes severe
Bradycardia.
Bradycardia, yeah. Right. If your patient isn't tolerating this from heart rate, blood pressure, definitely you want to wean this off.
Is he just on Dex now, or is
Yeah,
he
just
still
on, we're just on
I thought he was still on
dexmedetomidine.
propofol.
Yeah. Sorry, I didn't make that clear. So now we're just on dexmedetomidine 1.5. So how you wean this is very, very situationally specific. But basically, it does take a while for Dex to kind of fully wash out. It's a while for it to get therapeutic. It's a while for longer than propofol for it to wash out. So decreases by decreasing from 1.5 to 1 is reasonable, and then wait 30 minutes to get the full effect of that decrease is probably what I would do. Any additional thoughts on that scenario? The problems you run into when you're weaning Dex or you're doing spontaneous awakening trials in general? Okay. Reed, when you asked that question, what did you have in mind?
I mean, it's just sometimes kind of like what you're talking about. It's just let's cut it in half, shut it off.
Yeah.
This is kind of just from one extreme to another without
Right.
really knowing.
Yeah, it helps.
But, like when somebody just kind of comes in, hasn't seen the patient per se,
Right.
like how they react, and it's just no real parameters, I'd say, or
Right.
guidelines. for-
Yeah, and I think it's partly just because it's so patient specific. Because some patients, as you guys know, they're really like swing or very labile in terms of their mental status, if on some sedation versus no sedation, and others are kind of more tranquil regardless of what you do. So the tranquil ones, it makes sense to totally shut stuff off. The ones that have agitated neuro exams, to me, that's a situation where it makes sense to wean rather than shut stuff off. And dexmedetomidine, as you guys know, it can obviously be continued through any extubation. You never have to turn it off completely. It's hard, for extubating on propofol, generally you want propofol totally off. It's really kind of a dicey thing to extubate somebody while propofol is still running because the ET tube.
Cold blue.
Where?
Oh my God.